on very unexplained topic of sudden fetal death prevention. Dr. Manish is a professor and HOD in Scientific Research Institute, Mavi Hospital, Manish IVF Center, Sai Baba USD Center. Special awards, there is Dynamic Indian of the Millennium by KG Foundation, Gynec Excellence Award by Foxy 2020, Commendable Editor-in-Chief by IELN SRF in 2021, an icon of gynecology in world in 2024. Total 53 resident passed to doing residency and a Foxy recommends ART, IUI, IPS, ICSI and USC training 2D, 3D, 4D and color Doppler center. ICOG fellowship in reproductive medicine and laparoscopy. The publication 8 books by JP Publication, total 60, 45 paper and 5 paper in IGPCR, 2 paper in IGR COG International. Total 768 presentation and faculty conference and webinar. I welcome Dr. Manish Pandya.
Thank you, madam. Thank you for kind words. You can scan this through QR code scanner. One is of his Orchid. There you can find my 140 publications. And second is YouTube. You can see more than 170 videos over there. So it is very good educational channel. The moment child is born, mother is also born. She is dead, mother is something new. With the blessings of mother of mine and so many mothers, 3 books written by us is recommended in Royal College as a reading material. And I must thank Surat. And Vinodini might have forgotten, but you are the first person who had given me presentation in 2005 in Labour Conference when Shyam Desai was president, Uday Thanawala was secretary, and you are the scientific chairperson. Dr. Daftari has told you that Manish will present the patient. We don't know each other. You don't imagine the छोटा सा बच्चा आज चिंगारी. So thank you very much. And from that day, Chandi Stars, I must thank Dr. Bhatt also. He had supported me like anything like a son to give me 3 presentations on the same conference. Bartograph, twin presentation and IUCR. So from first conference, I become faculty and till today I am enjoying the success. And for Surat, I never said I traveled whole night to come here at the Surat. From Surendranagar, it takes 8 hours to Surendranagar to here. But commitment is commitment. So I must thank Surat, and almost every year I came to Surat for giving different presentations. 2 books on fetal echocardiography, 2nd edition on IVF by DC. I am editor-in-chief of Indian Journal of Obstetrics and Gynecology. This is Corpus recognized journal. Yes? So? QR code, that will come again. Don't worry. If you stay up to the last, it will come again. So thank you. This is a Scopus recognized journal, so those who want to publish their work, they can publish. And somebody wants to get international, I am also associate editor in Open Air Journals in Obstetrics and Gynecology. QR code. Last year at Copenhagen, I was supposed to be in Amsterdam today because from today Ashray is starting, and this year fortunately I got 2 presentations, but of the social commitment I was not able to go to Ashray. Last year Ashray I did an interview of Dr. Manish, and it is available on my YouTube channel. It is a privilege to take whole day history with Dr. Manish. Why fetus commit suicide? What you mean by sudden fetal death? How we can prevent? This paper was published with my resident Mehul Sangrani. He is practicing in Surat only. In Sivsa we have studied 110 cases. Why fetus commit suicide? That is a burning question. If you want to prevent suicide, you must know what are the causes of suicide. Here almost all the patients are below the age 30. Most of them are primary. 30 to 35 and more than 35 are very less. If you find out the cause, idiopathic was the most common cause. Next come cause abnormality, congenital anomaly, hydros and RH incompatibility, which is risk in number. Primary caters very high, so don't think that primary doesn't get sudden fetal death. They are highest in our group. So always prepare. Whenever lady comes, she is a potential risk anytime. she can go for any untoward thing. So every pregnancy is precious for us as well as precious for them. Because for you there are 100 labor patients waiting, but for her it is the only baby in utero, and that we have to survive. And then still today we are doing in our practice. See the different causes. Why there are sudden death? PIH, preeclampsia, eclampsia, abruption. You can't believe that abruption will come with sudden gush of vomiting. Patient was alright, and NST was good, she gone home, and suddenly she has got 2 bouts of severe vomiting, and you won't believe the placenta had abrupted and she came with IOD. That we can't prevent. But if we tell that patient, suddenly nobody dies suddenly. We are practicing medicine, so we all know. It is only in the Hindi movies that the patient will die. Here, God gave you enough time to survive. And that golden hour or that golden moment, we have to catch to survive our babies. Jaundice is very bad. There were 2 very bad patients with jaundice, and one of them succumbed with jaundice and IUD. So jaundice is also very rare. Rupture uterus, we all know we can't do anything. Diabetes is increasing. I don't know how many of having diabetes in this group, but it is increasing like anything. Why our pancreatic depletes the secreting insulin, I don't know. But diabetes is increasing much more in doctors. Postpartum and infection are the other causes. Idiopathic 28 case, cord accident, cord entanglement. That's why they have given the title. Why fetus commit suicide? Okay, non-induced hydrops congenital anomaly. If you see, most of the cases are PIH, abruption is the highest cause when there is eclampsia or preeclampsia. So if we tell our patient that these are the warning signs, you can prevent the sudden death. Then how to deliver? Usually they came with spontaneous labor. So many times we are inducing with 25 mesoprose or cemebrine. Only few patients have to go for cesarean because of the big and macerated baby are not able to come outside. What happens post delivery? We are thinking that PPH will be the highest. No. In IUD, you won't find that much of PPH unless and until it is long-standing IUD. Then there are chances of DIC. DIC is also comparably less, but most common. And we all have to think about psychological disturbance of that lady, because she has scattered 9 months in utero, and suddenly you say your baby is dead. Won't believe what a big shock on their heart. So many times my teacher used to say it is better to have scar on uterus rather than scar on heart. Don't go for delivery that much if they are giving a baby which is congenital, which is morphologically abnormal. You can have a CP child. Better to do cesarean section. One or two cesarean. Unindicated cesarean section will be pardonable unless and until you give a healthy baby to that lady. So better to have scar on uterus rather than scar on heart. Once baby is there, how much loss she has to suffer? And that's why we have to take special care of that psychological support, and only one maternal mortality they are told with jaundice patients. So what we mean by infrafetal death? If you go by definition, fetal death before onset of labor or fetus with no sign of life in utero after 20 weeks of gestation. Definition varies according to gestational age and birth weight. WHO says an infant delivered without signs of life after 20 weeks of gestation or weighing more than 500 kilograms when gestational age is unknown. Then WHO again says different medicine. Fetal death means death prior to complete expulsion or extraction from the mother of a fetus, irrespective of the duration in which is not an induced or termination of pregnancy. We know that there are stillbirth and there are IUDs. There are fresh stillbirth, vaccinated, retained more than 12 hours, early that is 20 to 27 week, and late is 28. What are the risk factors? If we know the risk factor, we prevent the maternal. Most common is obesity, and believe me, it is increasing like anything. I have seen that 6th standard group girl with 70 kg weight. 6th standard girl. All the ladies, they are coming around the BMI 25 to 30, and now they want to get pregnant. They want to get married, and luckily they got very good groom with this much of kg weight also. When she become pregnant, we have to be very much careful. Career oriented lady. I want to first make the career. Then I will think of babies. These are the potential risks in which you find rather. Believe me, smoking, gutka, alcohol is increasing in our society. When we were resident, we don't know that ladies are coming with gutka. Now you see, ladies are always coming with gutka and chewables. Surat માં કેવું છે ખબર નથી. ગુજરાતમાં every ગામડા, every lady is eating tobacco. And you know how much tobacco gets harm. Infection, malaria, hepatitis, influenza, syphilis, toxoplasmosis, they all can cause sudden fetal death. Diabetes, hypertension, thyroid, pre-existing diseases like anemia, epilepsy can also cause. Autoimmune disease, RS incompatibility, sometimes hyperpyrexia. I had seen a lady with 108 temperature and sudden fetal death. We have to put them on the cold sponging, no binary sponging, nothing antibiotic, but that we have to do the cold sponging, even though we are not able to survive with it. These are the things in which at that particular time you can't use cesarean section at 106-degree temperature. But we have to be careful. So if we know the cause, we can prevent the sudden fetal death. Obstetric cause like abruption, BPRO, multiple gestation, preterm, dystocia, and uterine rupture can cause. What are the fetal causes? Multiple gestation, IUGR, congenital anomaly, infection, hydrops, G6PD deficiency. We can see G6PD deficiency in families, just we have to think of. And now this, because after giving so many different varieties of iron and HB is not increasing, then you have to think of G6PD deficiency. We are not thinking, we are giving PD, patient is fine, but you have to think why her HB is not improving, whether she is thalassemia or whether she is G6PD deficiency. Placental causes. In my Manish 4269 challenge, there are very good presentation of placental insufficiency. Winnie is looking placenta very carefully. Otherwise, what we are looking placenta, right, left, anterior, touching internals, not touching internals. You have to see placenta very carefully. Look at the placenta from the insertion to its end, where the cord is lying, whether there is calcification is there or not. What about the nita bucci layer? If you know about the nita bucci layer, you know that there is no perlita. Yesterday, very good presentation given by Dr. P. Kesha. At that time, you had heard of nita bucci layer. It is not Indian, it is neta bucci, but for Indian, we are making nita bucci. It is neta bucci. So, there is a one big book on placental insufficiency is there. How many different varieties of placenta we know? So if you know the placenta, absorption, cord accident, placental insufficiency, previat, weak transmission syndrome, chorioamnionitis, fetal-maternal hemorrhage, iatrogenic like ECG now nobody is doing, but drug overdose can cause sudden fetal death. So how you can diagnose? Absence of fetal movement, regression of the size of abdomen, gradual regression of the uterine size, tonis diminished, fetal movement not felt, fetal heart sound not heard. Diagnostic, nowadays ultrasound is very common. Everybody has got ultrasound that put up now. Now we have facility of pure ultrasound coming in office, older ultrasound machine goes in labor room. So when sister know that, now they are not hearing the heart with the doctor, they are just watching the heart with ultrasound. Because older machine nobody is taking, and if they are taking at very less price, so better to keep those machine in labor room to see our labor patients. If baby is died, we all know about the Robert sign, Spalding sign, Ball sign, Helix sign, crowding of rib shadows. This all will be present in a macerated IODs. How you systematically approach to all these patients? Varied recommendation depends upon the expert opinion. No rocket science. Studies ongoing by Stillman collaborative research work and optimum evaluation is must for. Why we want to study? First and foremost, we want to keep that baby should not die in. If dies, then what are the chances of recurrence? What are the future preconceptual counseling? What will be our future pregnancy management? What are our plans for prenatal diagnostic procedure? And how we manage that neonate? Suppose she had IUDs for 32 weeks, and now we don't want to make IUDs. We are worried, patient is also worried. Sometimes we have to take preterm labor. They are worried that 32, sometimes my baby dies. Better to keep this baby out. When it is mature, baby weight is around 2 kg, remove it. Then we have to take one very good precaution regarding the neonatal. Obvious cause, no further testing limiting of cord blood for accident and identification. Always take very good history. Good morning, PK sir. Just now I had taken your name of Rita Buchariya because we had delivered very good presentation. You insist on the present actor, and then Rita Buch is coming. If Rita Buch is not there, present actor can go inside. So there is no Buch, there is no Buch in placenta, there are chances of accident. So we have to take very good history. Can anybody give me the definition of history? રોજ આપણે લઈએ છીએ શું પૂછીએ છીએ આપણને હિસ્ટ્રી રેસિડેન્ટ take history. History study of past and light of present to have good future. We are taking history in present. Patient is narrating the past for having good future. Why no? Because recently I completed my PhD in history. 2024 December I will get my PhD degree in history. સુરેન્દ્રનગર જિલ્લાનો સુરેન્દ્રનગર સ્વતંત્ર સંગ્રામમાં ફાળો ભારતના સ્વાતંત્ર્ય સંગ્રામમાં સુરેન્દ્રનગર જિલ્લાનો ફાળો એટલે ગમે છે મળતા રહીએ. So we have to take very good history. Always see the gloss examination. Always see the SP features. Don't throw them in dustbin. Do the verbal autopsy. If you are not doing autopsy, we are doing autopsy at our place. If you are not doing, do the verbal autopsy. Find out the cause. See SP infant, see for umbilical cord, placenta, amniotic fluid. Usually we all have done forensic medicine. Now see this baby as a culprit. Why she died in utero? Why he died in utero? And why she has to lose a fetal loss? So we have to see just like policemen. If you are doing fetal autopsy, it is very good. Good morning, President Sunil Kumar. TB investigation and maternal investigations. Always take history of recurrent abortion, congenital anomaly, abnormal karyotype. If patient has taken a karyotype, abnormal karyotype, you have to see hereditary condition, developmental delay, maternally all diabetes, hypertension, thrombophilia, autoimmune disease, severe anemia, epilepsy, constituency. In our Surendranagar, we have got so many Khojas married in between, so many Musalman married in between. Roti bar jai, mitti bar no jai. And you have to see the pedigree of congenital disease. बहुत सारे लोगों को मैं बोलता हूँ अभी तो तेरी बहन थी अभी बीवी होगी आप बोले मेरे भाई बहन डिग्री मारी बहन थी 2 વર્ષ में जो तो बच्चों के साथ so that consequently we have to see because then we can diagnose what are the things runs in family because they are not changing their blood. It is the only Brahmin who has got their pedigree right from all the gurus. Suppose I have got Vishwamitra's concept, but I know that I can't marry with them. So all genetic code is there with Brahman. We know from which Prabhavan we are, from which Vidhi we are. So everything it is destined. We can't marry. But here, Mama Bhai, Jai Jinendra. So post-obstetrics, baby with congenital anomaly, IUGR, hypertension, placental abruption, recurrent abortions. Always see the cause description of infant, how malform it is, what is skin staining. If it is thick meconium, you can see gold staining. There is a blue staining. One कर दे बेटा मुझे तो तुम्हारे पास कोई क्या नहीं हमारे क्या चुना degree of maceration color code sorry always see the umbilical cord prolapse enlargement in the neck arm legs hematoma stricture number of vessels and length always see the amniotic fluid color volume if it is blood is there whenever you see the abortus of IUGR or baby dying in utero wait the placenta. See placenta for staining. See for any knots are there. See for structural anomaly, velamentous. Different variety of placenta, medullary placenta. You see for them. See for edema in the placenta. See for stain and thickening of the placenta. Hyperplacentosis or there is hypoplacentosis. Calcific acid is there or not. If you are doing fetal autopsy, there are 2 important steps in SP evaluation, crucial for future pregnancy. Appropriate concern we are taking. Ideally should be done by perinatal pathologists and good trained gynecologists. If denied, patient says I don't want to go for autopsy, always try to have an MRI. It is easily available and for research purpose in Surendranagar we are doing MRI for free for these autopsy patients. Take radiographs, photographs. If possible, go for fetal karyotyping. See what is dysmorphic features are there in fetus. Fetus is hydroptic and signs of congenital anomaly. Just I will show you the 2 clips. Audio चालू audio So these are the two different babies. One has got hypoplastic. Don't worry.
Later, you can see this is letter going behind. Later.
How many of you have doing autopsy by your hand?
You can see the
Very
this is urinary letter. This is urinary letter and this ureter. This ureter are going directly into this urinary
So
letter.
if patient has got heart disease, you have to do autopsy of the heart.
This is fetal heart. You
They
can
are not
see
going in detail because
this
I
is the
was-
appendix of the heart.
But we have to see all these things, or you have to take sample of amniotic fluid. You have to take fetal blood sample. If it is not possible, take placenta in a block or 1.5 centimeter and costochondral junction or patella. That is for future CGH and fish. That we want to know how baby died in utero. For placental investigation, always see for chorionicity, cord knot, vessel thrombosis, infarction, thrombosis, abruption, vascular bar formation, signs of infection. Always take placental block below the cord insertion. Take umbilical segment 1.5 centimeter. The centers for infection and bacterial culture for E. coli and Listeria. How you have to do maternal evaluation? Routine CBC, electrophoresis, diabetic testing, TFT, additional tests you can do, take your Beckett test and serological test for TORCH, syphilis, parvovirus, antiphospholipid antibody syndrome, thrombophilia screening, bile-acid and urine toxicology. Now abroad there are patients who have got very high dose of cocaine, amphetamine, they can be associated with abruption. And same way we are doing cocaine test in the urine, you can do the same test of cocaine and amphetamine in urine toxicology department. All these sports authority people, they are doing this toxicology test. You can do same for our patients to know whether they are consumed cocaine or amphetamine. How you manage? That depends on the single and multiple gestation, at which gestational age death has occurred. And this should be around to patient wish, but always mention that I will try my level best to do your normal delivery. Memory is there in 110 cases, good morning, your paper was published first and that I had shown. In 110 patients, you have to go for cesarean in only 2 patients. So if you give them proper counseling, પહેલો જ ક્વેશ્ચન આવશે ઝેર ચડી જશે માતાને કંઈ થઈ જશે ડુ પ્રોપર BTCT ability induce the labor. If spontaneous labor is there is no question. If you induce the labor and she won't deliver within 24 hours, usually the dictum is Divesh bhai, never let the sun to set twice in labor. Newer dictum is never let the sun to set in labor. Because with program labor, active management of labor, we are doing labor within 12 hours. So give them option. જો 10-12 કલાકમાં ડિલિવરી નહીં થાય તો અમે તમને સામેથી સિઝેરિયન કરી દઈશું. But if they are constantly hammering on your head and you feel that this baby is macerated, this baby is more than 4 kg, progress of labor is not there, if that type of indication you go for cesarean section. Otherwise, out of 110, only 2 patients we have to go for cesarean section. So all 118 patients delivered vaginally, either spontaneously or by induction. So we can give them option. And if you take the responsibility on your own head, ઝેર ચડશે તો મેં ઇમરજન્સીમાં અમે કરી દઈશું. અને અત્યાર સુધીમાં કેટલાય ઝેર ચડેલું જોયું. આટલા બધા ગાયનેકોલોજીસ્ટમાં કેટલાય આયુર્વેદિક ઝેર ચડેલું જોયું. પેશન્ટના સગાને ઝેર ક્યાંથી મગજમાં જાય કંઈ ખબર નથી. પણ જેવું આયુર્વેદિક તમે કહેશો એટલે એના સસરા એને કંઈ ન થવું. એ સાંભળીને જ આપણને બીક લાગે. પણ છતાં આપણે આપણું 100% આપવાનું. So always do expected management post delivery, emotional support. Keep them on non-maternity ward. બાજુવાળું બચ્ચું જોશે ડિપ્રેશનમાં જશે. વેલકમ કમલ મેડમ. તમારી જ રાહ જોતો હતો બતાવી. Okay. So counsel them properly. Assure that whenever you find the cause, always try don't repeat that cause in second delivery. What RCOG recommended for future pregnancy? Always take detailed history, evaluate the workup for previous stillbirth, determine the risk factor. If she is smoking, cessation of smoking. If she is obese, weight loss, genetic counseling, medical problem like diabetes should be managed by a thrombophobia workup. The risk occurrence is 7 to 10 per thousand live birth. So if she has got one IUD, we prepare 1 week prior to do any intervention if it is needed. Take them on a higher risk. I must say every pregnancy is high risk because nowadays when I started my practice I am doing more than 200 deliveries in a month. Now it is reduced to 60. Why? Because so many gynecologists are there. So the work is that delivery is still the same, but the workflow has distributed. So all the patient will come to you is precious. Previously we were delivering more than 6th, 4th, 7th gravida. At maximum I had given the 13th gravida. And by mistake I had asked, what is your last menstrual period? She said, when I got married. Then I had never seen which color menstruation was there because I am 13th time pregnant. So now this will come in your history only. Nobody will see 13th gravida in near future. So we are happy that we are able to deliver that type of lady. Always take detailed sonography first trimester if they are not doing. Tell them, send them to the fetal medicine specialist like Vinodini. They will do very good screening of NT, NB and so many things they can see in first trimester. Always give folic acid. This is a preconceptional pill, or we can call it an engagement pill. And now UNICEF also recognized and we have to thank Professor Suresh that he has meant this folic acid 5 mg as an engagement pill. Only thing to prevent urological prevent is 5 mg of folic acid. Supplement there is already starting from engagement because if she is engaged, nearly she will come to us. So when miss the period, then it is bad news. But when Mrs. miss the period, then it is a good news. So when she is starting going for Mrs., give them the benefit of folic acid. Second trimester, do detailed ultrasound, maternal. Just as this is only few slides and same common medicine. So don't worry. Third trimester, we have to go for sonography and surveillance. Start from 32 weeks. 1 to 2 weeks earlier than the prior birth. Watch for fetal heart, BPP and support assurance. I will take only 1 minute. This is very simple thing. DFMC chart. How many of you are giving this exercise to our patients? And you will never regret it. You will never regret it. Because baby is talking directly to the mother. If Abhimanyu is knowing everything in utero, the last part he was not able to hear because her mother was sleeping. So tell our lady that every day you have to be with your baby for 3 hours. Chant any mantra that you know. Be with your baby. Baby will give you assurance that I am here. And if you see in this group, there is no IUD, there is no death on DFMC part. You have to give them the cardiac 10 point. And in my OPD paper or my consulting tab, we have a DFMC chart mandatory for every patient. For high risk patient, it is good. For every patient, if you give, they will better. Doctor is concerned for our baby. Doctor is telling that how to monitor our baby. 3 hours post lunch, સવારે 1 કલાક, બપોરે કલાક, સાંજે કલાક. આખા દિવસમાં બાળક 10 થી 20 ની વચ્ચે ફરકવું જોઈએ. 10 થી ઓછું કે 20 થી વધારે ફરશે તો હોસ્પિટલ આવી જવાનું. We had so many babies we had saved. And madam, now you are telling figure 32,498 deliveries. We have got list them because of less fetal movement. They came to us, we had delivered the baby who has got only 60 sugar because mother was diabetic. She knows that baby has not moving. We had done the emergency cesarean section. We see that baby has got 40 to 60 sugar only. So we had not done the intervention, baby will die or baby will commit suicide in utero. So there are things for prevent. No fireproof method, lose weight, give folic acid. If you have got hospital like us, DNP, residency hazards, always go for stillbirth audit. So in summary, etiology is unknown, optimal evaluation based on future investigation, counts is proper, allow patient to sit and pray in isolation, take photographs of footprints of IOD baby, reassure and guide that in future you will be ready. This is inference given by Vibhul. Then if there is a low PEM-A and high maternal fetal serum alpha fetoprotein in your triple marker or double marker, beware that this baby has got higher risk of committing suicide in utero. So main need is difficulty because they are resisting to enjoy the success. I must thank so many companies. 83 companies are using my paper in digestone out of 114 papers. So at the end, everybody should be happy. Just give me the word.
Thank you very much.
The time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here.
Thank you very much. Thank you, your society. So when you lose a person you love so much, surviving the loss is very difficult. So do not let any fetus to commit suicide in you. Give them a healthy baby. Again, madam, this is two QR code. Those who want to scan, they can scan this QR code. One is of Orchid, where you can find 114 papers, and one is of UP. Thank you very much. And lastly, please vote in canvas for MC Patel. He has written very good things. Two things define you: when your patience, when you have nothing, and your attitude when you have got everything. Thank you. Thank you very much.
Thank you very much, sir, for informative lecture. Nicely elaborate the topic. Thank you very much.